first-in-class molecular glue degraders for prostate cancer treatment. First, I will start with our team. Myself and Sherry, who is also on the call, as you saw earlier. We are co-founders and academic investigators. I'm a professor at Weill Cornell. Sherry joined my lab a few years ago as a postdoc, and she rose very quickly to assistant professor level. So she's a star, and she's leading this project from my group. Casey Nicolaou, medicinal chemist extraordinaire, long-term collaborator of mine, and he helps us with his chemistry expertise. We have also an expert advisor team, Emmanuel Antonarakis. He's a leader in prostate cancer developmental therapeutics, and David Scheinberg. He's the chair of the Center of Experimental Therapeutics at Memorial Sloan Kettering Cancer Center, and he has developed several oncology drugs. And we also have built a team of venture advisors. So here, prostate cancer, let me give you some background. So prostate cancer is the most commonly diagnosed and second leading cause of cancer death in men in the US. And it is actually more common than you think. 1 in 8 men will be diagnosed with prostate cancer at some point during their lifetime. And the recent Lancet Commission on Prostate Cancer, published last August 2024, is warning governments to prepare for the huge surge in prostate cancer newly diagnosed cases, going from 1.4 million newly diagnosed cases in 2020 to 2.9 million cases by 2040. Biologically, prostate cancer is driven by androgen receptor signaling, therefore making androgen receptor the most clinically validated target in prostate cancer. As you can see, the therapeutic landscape in the $11 billion US market alone, AR inhibitors, the blue here, represent 90% of all prostate cancer therapeutics. And now, all of these drugs in the blue market space target the ligand binding domain of the androgen receptor. And why is this a problem? The problem is that a direct result of all these treatments is the expression of AR splice variants that lack the ligand binding domain and drive treatment resistance. Treatment resistance is the #1 cause of prostate cancer mortality. Among all the variants, ARV7 is the leading cause of treatment resistance and is currently undruggable. These are the clinical data that show that patients that have ARV7 expression in their tumors are resistant to current standard of care treatment, AR-directed therapies, and taxane chemotherapy. This was the work published by our clinical advisor, Emmanuel Antonarakis. This is from our group. And all of this data suggests that ARV7 inhibition is a current and urgent clinically unmet need. And currently, there is no ARV7 inhibitor, leaving patients with limited therapeutic options. Now, to address this gap, we performed a high-throughput phenotypic screen looking for ARV7 inhibitors. We screened 170,000 small molecules and identified the first ARV7 small molecule inhibitor. So the mechanism of action of our inhibitor is that it degrades ARV7 protein. It also degrades the parent receptor AR protein. And unlike traditional small molecule AR inhibitors that only target the ligand binding domain, leaving ARV7 undruggable, our degraders eliminate completely both AR and ARV7 by proteasomal degradation. In addition to that, as AR ligand binding drugs are associated with incomplete and transient target inhibition, and they are very prone to resistance. through mechanisms that involve AR amplification, ligand binding domain mutations, and AR splice variants. On the other hand, our compounds completely eliminate the targets. They have potent and rapid onset of action. They work within 4 hours of treatment, and they avoid treatment resistance. So we have also identified that our compounds bind at a unique binding domain that involves the N-terminal domain. And now, having this unique binding domain adds to the unique features of our drugs. First of all, our compounds are the first and only molecular glue degraders that take out both parental AR and lethal variant, ARV7, in a single treatment. They have a unique binding domain that is shared by both AR and ARV7. And by targeting this domain, it allows us to treat all prostate cancer patients, both sensitive and treatment resistant, and both early and advanced stage. Finally, our compounds reverse existing standard of care treatment resistance, and they have the potential to delay the onset of treatment resistance. So this is our competitive landscape. Here is some of the AR-targeted ligand binding domains, either approved standard of care or in early clinical development or preclinical. As you can see, none of these target ARV7, and none of them reverse enzalutamide resistance. In contrast, our compound targets both AR and ARV7, has a unique mechanism of action as a molecular glue, and inhibits canonical AR, ARV7, and reverses standard of care resistance. So we founded ARMA Bio in 2022, and since then, we have performed a number of key experiments, from lead optimization and structure activity relationship studies in vivo PK. We're currently working on in vivo efficacy studies. We have obtained $3.5 million in non-dilutive funding, including $2.4 million from NIH Fast Track, STTR, SBIR funding, Daedalus funding to de-risk our invention, Dry-Eye TDI funding, exit funding from CURE and the Deerfield Management and Aim High Women's Venture Competition. And let me go back. I'll just end here. Hold on. So right now, we are seeking $15 million to successfully complete IND-enabling studies, including GLP manufacturing, GLP toxicology, and everything else, so that we can obtain IND clearance and go into phase 1 clinical studies. And with that, I'm going to exit and stop sharing. Okay.
Thank you. Before we go to the main floor, does anyone in the audience have any questions for the ARMA Bio team? Okay, we have one that just came in. How would your compound be administered?
Oral. So we have an orally available compound. We're doing the in vivo efficacy studies. We have done PK studies. We have a very favorable PK profile, and market analysis in the prostate cancer space shows that oral availability is the preferred mode of administration.
Thank you. We have a question. How does this compare to Orgoviz oral? I'm not sure if you're familiar with that.
No.
Okay.
What is the mechanism of action of this compound?
Not sure. Another question.
This is a different kind of ADT treatment, Abby.
Oh, yes. Okay. That is a great question. So our compound is completely different because a direct result of ADT is the generation of AR splice variants, ARV7. The ADT treatment does not target ARV7 because it requires a ligand binding domain. So we have the only compound that has a unique binding mode, shared between AR and ARV7 and eliminates both. So it's a very different and unique mechanism.
Thank you. Another question is, what is the half-life?
Oh, the half-life of the current compounds is about 5 hours. The half-life, you mean elimination for the PK studies? Yeah, 5 hours.
Great. We have a question. Will Deerfield lead the Series A? I'm not sure if that might be a little bit too far in the future.
No, not yet. We're not there yet. We just participated in the exit competition and we got first place, $250,000. Right now, I'm not going to disclose the names of the ventures, but we are talking to a few ventures who are very interested in our technology.
Thank you. All right. Any last questions here? The ARMA team will be at table 4, I believe, on floor 2, or they'd be happy to go into more detail.
Do we go to table 4 right now or to the main floor?
You will in a second. So
okay, thanks.
We will close out this floor and then you will be brought back to the main room. Well, then
I think they have one more question. I just saw it.
Sure, yeah. Have you considered co-development, pharma partners, or licensing options?
Excellent options. Excellent options.